Hello. Let's continue then with our case of chest pain. We had a 50-year-old man with 1 hour of chest discomfort, an unremarkable ECG and initial troponin. However, in the emergency department, he's experiencing worsening chest tightness. We're going to start our initial management and intervention as we're talking with this patient. And we're going to begin by giving the patient an aspirin, which is an antiplatelet agent, have him chew that up. And then we're going to give some oxygen because this patient had a rapid respiratory rate. Not all patients with chest pain need oxygen, but if they feel short of breath, have abnormal vital signs, or are ill in appearance, oxygen should be applied. We are also going to try to control the patient's pain by using a vasodilator, specifically nitrates. So internationally, we'll frequently use sorbitrate. Within the US, we use nitroglycerin. These are direct vasodilators that can be given in multiple formulations, such as sublingual or IV. We don't want to give these if the patient's been on a phosphodiesterase inhibitor, is bradycardic or significantly tachycardic, or has a very low blood pressure, less than 100. If nitrates are not working to control the patient's pain, we can also consider other pain medications. In the United States, we frequently use narcotic analgesics such as morphine or fentanyl for these patients. You just have to be careful because side effects such as nausea, flushing, and hypotension can occur, which can mimic the patient getting worse from a cardiac cause of chest pain as well. Of these therapies, which we give frequently to patients with chest pain, which has been shown to decrease mortality in patients with acute myocardial infarctions? The answer is aspirin. Aspirin or antiplatelet agents have been shown to reduce the risk of mortality, a relative reduction of 23%, so fairly significant, the same as fibrinolytics. While we're rechecking on our patient, he suddenly becomes unresponsive, and we look up at the monitor and we see this rhythm. So you can instantly see that this is a wide complex tachycardia at a very fast rate. So any rate greater than 140 with a wide complex tachycardia, you should probably assume that this may be ventricular tachycardia. And you have to remember that 90% of deaths from a heart attack are actually secondary to arrhythmias, not congestive heart failure. And these deaths occur early. 60 to 70% of these deaths occur prior to the patient arriving at the hospital, but they're also at a high risk in the emergency department or urgent care setting. If you see that wide complex tachycardia, you should assume that this is ventricular tachycardia and not think this is a sinus tachycardia or supraventricular tachycardia with an aberrant conduction, such as a right bundle branch block or a left bundle branch block. In a patient, when we see that wide complex tachycardia, we want to be prepared to intervene quickly and defibrillate the patient. And if we can do that rapidly, we have a good chance actually of breaking that cycle and getting the patient back into a normal sinus rhythm. So in our case, the patient was on the cardiac monitor, and we recognized early that they went into the wide complex tachycardia, and he was rapidly defibrillated with a high joules, and we found a return of pulses. The patient became conscious, and we noted sinus rhythm on the monitor. Repeat ECGs should be done in all patients who have possible ACS and likely ACS because ECG findings can change over time. We especially want to do these in patients who have had a change in their status, like our patient, who have had a change on the monitor, or anybody whose symptoms have altered as well. We recheck the cardiac monitor after defibrillating the patient, and we see this, and we can see instantly that we have J point or ST segment elevation compared to our TP segment. So we get a repeat ECG in our patient, and although the patient had an initial normal ECG, we see significant abnormalities right away. We see ST elevation in leads 2, 3, and AVF. And these are contiguous leads, and so with greater than 1 millimeter of ST elevation in these leads, we have to think about an ST elevation myocardial infarction. Looking closely at the ECG, we actually see some ST depression as well in leads 1 and AVL. These are called reciprocal changes, and these increase the likelihood that the ST elevation we see in the other leads are due to a heart attack or AMI. Don't forget the anatomic lead groupings, because you have to have ST elevation, but they have to be in leads that go together, that when you look at the anatomy of the heart, makes sense. So here are our lead groupings, and we can see that 2, 3, and AVF are all inferior leads looking at the inferior part of the heart and the right ventricle. So these leads do go together, and we think we have an ST elevation MI in the inferior leads in our patient. Be careful then in these patients with inferior MIs. These patients can have a blockage either in the right coronary artery, which helps to feed the inferior part of the heart, or the left coronary artery. But in either case, whichever artery is blocked, these patients might have dysfunction of the right ventricle. And if the right ventricle is involved, you have to be very careful using nitrates, because by giving them that vasodilator, they decreases the preload the patient sees in the right ventricle. And these patients are very preload dependent because their right ventricle is not functioning well. So they need a lot of preload or a lot of fluid and filling to make sure they're getting adequate cardiac output. This patient with a STEMI then would be a candidate for a reperfusion therapy, or opening the artery, by either using fibrinolysis, such as streptokinase or urokinase, or by using catheterization, or PCI. The preferred method depends on your hospital, your setting, and the timing of the patient's symptoms and STEMI. So in summary, you want to monitor these patients closely for dysrhythmia, as this is the #1 cause of death early in these patients. We want to obtain serial ECGs and serial cardiac markers in our patients. And if the patient has an inferior STEMI, like ours did, we want to be cautious with nitrates, because these patients are preload dependent and can get very hypotensive if they have an inferior or right ventricular involvement. So let's do one final review of our case. The patient presented with an hour of chest pain, and we rapidly evaluated and initiated treatment in this patient. We developed an expanded differential diagnosis, focusing on what was worst first. We monitored the patient closely and defibrillated the patient rapidly when he went into ventricular tachycardia. And we used repeat ECGs and cardiac markers to identify an ST elevation myocardial infarction and make sure that the patient got the appropriate intervention to save his life. So using these things, we can save our patients' lives with chest pain. Thank you.